Hello, and thank you everybody for joining us. Sorry about the technical difficulties, but we got everything worked out now. Thank you for joining today's webinar program. It's brought to you through the support of our sponsors and our expert contributors. The P&A is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The Pituitary Network Association is a nonprofit organization that relies on the support from our members and donors. During the webinar, please feel free to type in your questions at any time, but please note that all questions will be saved until the end of the webinar. We have allotted time to answer as many questions as possible. Any questions that are not answered will be reserved and answered by email. Today's webinar, Personalized Treatment for Patients with Acromegaly, is being presented by Dr. Adriana Ioachimescu. Dr. Ioachimescu is an associate professor at Emory University in Atlanta and the co-director of the Emory Neuroendocrine Pituitary Center, a premier tertiary center for neuroendocrine care for patients with pituitary tumors. She graduated in 1995 from Davila University in Bucharest, Romania, where she completed training in endocrinology with an emphasis on pituitary tumors. In 2006, Dr. Ioachimescu completed her fellowship in endocrinology at the Cleveland Clinic, where she remained until she joined Emory in 2007. Dr. Ioachimescu's research is focused on prognostic factors and novel treatments in patients with pituitary tumors. She has authored more than 30 peer-reviewed articles and several book chapters. Dr. Ioachimescu's clinical activities focus on diagnosis and endocrine management of pituitary diseases. Dr. Ioachimescu works together with Dr. Nelson Oyescu to provide streamlined, comprehensive care for pituitary patients. Dr. Ioachimescu, we truly appreciate you taking the time out of your schedule to be involved in our webinar program. We've already changed presenters, so it's all yours.
Thank you so much, Tammy, for this presentation, and I hope everybody can hear me. Today's presentation is about acromegaly, and here are the objectives. We are going to talk about why treatment is important for patients with acromegaly. We're going to talk about surgery, medical treatment, and radiation, when to consider each one of these and their risks and benefits in patients with acromegaly. But before talking about the acromegaly, let's zoom out a little bit and talk about the pituitary gland. The graph seems complicated, and this is the way things are. This is the master gland of the body. The pituitary gland that I'm circling now with my mouse is secreting a lot of hormones, and it has two parts, the anterior part and the posterior part. And it involves, and its functions are involve regulation of other glands in the body like thyroid, adrenal, testes, ovaries. Today, however, we are going to talk about growth hormone, and I must say that I cannot choose a certain part of the body or a gland when we're talking about the growth hormone. Growth hormone effects are on the entire body. So to simplify a little bit, the pituitary gland produces growth hormone that tells the liver to produce something called IGF-1 or somatomedin C. And via somatomedin C, growth hormone acts on the target tissues, the cells in the body, from the joints to the heart to the vessels and so on. There are some direct effects of growth hormone on target tissues, but our understanding today is that most of the growth hormone effects are mediated via IGF-1. A little bit about the diagnosis, and that's not something that we're going to focus today. Growth hormone is secreted in a pulsatile fashion. We reach high levels of growth hormone when we go to sleep, around 11 p.m. and midnight. And then throughout the day, if we're going to sample the levels, they're going to be quite different. Food influence growth hormone levels and so many other factors. While IGF-1 is a more stable indicator of growth hormone secretion. IGF-1 is a wrap-up of growth hormone pulsations looking 2 to 3 months back. So when the doctor talks to the patient with acromegaly, most likely both these two numbers are going to come into play. Growth hormone level, IGF-1 level. Acromegaly is a rare disease compared to the other types of pituitary tumors. In red here, we have somatotroph, which means growth hormone secreting cells, somatotroph tumors. These are represented in this light green color. And as you can see, there are other types of tumors like prolactin secreting cells or non-functioning, clinically non-functioning cells, and these are much more numerous. Overall, if we look at the population level, acromegaly is a rare disease. Those studies, most of them done in the 1990s and 2000, maybe up to 2012, show that in terms of new diagnosis of acromegaly, we see this in less than one case per 100,000 people per year. This is what's called incidence. But there is a possible trend toward higher incidence in more recent studies that needs to be confirmed. I'm not sure if this means acromegaly is becoming more frequent disease. It may simply mean that the physicians are more aware of it and they have better tools to diagnose it, like laboratory testing or imaging. Acromegaly affects women and men in the same fashion. There is no clear predisposition. And peak age at diagnosis is in the mid-40s. Now keep in mind most patients with acromegaly had some symptoms if they look back at their health for at least 3 to 5, even 10 years before the diagnosis. So diagnosis doesn't quite mean that this is when the disease started. The disease unfortunately started years before, and it is very important to diagnose acromegaly early in order to minimize the consequences of excess growth hormone on the body. So let's talk about manifestations of acromegaly. And this graph depicts an adult patient, because if we were to talk about children with excess growth hormone, fortunately those cases are rare. The situation is a little bit different because excess growth hormone in children means that they will become taller than their families. They will be giants. They may become giants. Now, in adults, this doesn't happen because the growth plates have closed. So what do we see in the patient with acromegaly? So if we look at the face, there are some features that are now more coarse. Lips are large, tongue is large, the nose is large, the skin is thick and now more wrinkled, something we call frontal bossing. And these features usually are noted when the patients go for family reunions or high school or college reunions. So pretty much they see folks who they haven't seen in a long time, and those folks say, something changed, you look a little different. What else can we see in patients with acromegaly? Acral enlargement. That's what physicians call that the hands and feet become wider. Patients need to change the shoe size or to resize their rings. Skin has more skin tags. The patients perspire more, and the skin is thicker. How about what happens inside the body? Well, many of the organs simply grow larger, but that leads to dysfunction. So, for example, here we have the thyroid gland that can become larger or can even grow nodules. The heart can get larger. This is called acromegaly and can be associated with dysfunction of the heart muscle, which can lead to heart failure. The liver is getting larger, hepatomegaly. Nephromegaly means the kidneys are larger. The colon is larger, and there is an increased frequency of colon polyps compared to the general population, even if the patient has been diagnosed at a young age, so even before age 50, when we all should be screened for colon polyps. What else happens? Well, the breasts. Women can experience milk discharge. Men can experience tenderness, increase in breast size. The vessels. 4 out of 10 patients with acromegaly have hypertension. and the joints. There are issues that are similar to what we see in osteoarthritis, so morning stiffness, pain, deformities. So do I need to convince you that treatment with acromegaly is important? I really don't think that there is. I think I've made a pretty strong case that treatment is important. Here's what we want to achieve. We physicians who treat patients with acromegaly, pretty much 4 big objectives. We want to control the complications. For example, a glucose problem, diabetes mellitus, occurs in 2 or 3 out of 10 acromegaly patients. Heart disease, cardiomyopathy, we want to be able to avoid that or to control it by treatment of growth hormone levels. Respiratory problems like sleep apnea, benign or malignant tumors, and I would highlight here the colon and thyroid, but really the patient with acromegaly has to be careful and be up to date with everything that is appropriate for their age in terms of cancer screening. Second, we want to control the tumor. We do not want the patient with acromegaly to suffer with headaches from too much growth hormone or from a large tumor, or to have vision loss because the tumor impinges on the optic nerve. Tumor growth is an important factor. Decrease mortality. Several studies were done and showed that if we're going to treat acromegaly patients and achieve normal numbers, patients will live as long as the other general population in the same age group. And finally, but it's not the last one, it's just listed last, we want patients to be as much as possible free of symptoms, and we want their quality of life to be improved. We know acromegaly deteriorates the quality of life. Here are the symptoms that a patient with acromegaly should discuss with their doctor at each visit, just to understand how severe is the effect of acromegaly on their body, and also to try to quantify whether the medicine is working or not, or any type of treatment that has been done for acromegaly. Headaches, excess sweating, swelling of hands and feet, fatigue, and joint pain. However, the joint pain, even though it typically does get better with control of acromegaly, it's the least likely to disappear. As I told you, it's the cartilage problem, the bone-on-bone type of joint problem that is really hard to turn around. So let's talk about treatments, and the experts agree surgery is the first-line treatment for patients with acromegaly. The approach shown in this figure is transsphenoidal, so usually through the nose and the sphenoid sinus. And some neurosurgeons use a microscope, some use an endoscope. It really doesn't matter what they use, as long as they are experienced. So talking about factors that influence surgical outcomes in patients with acromegaly, it is important to choose a neurosurgeon who does a lot of these surgeries every week and every month and year after year, and a center that has treated these patients over and over again and is ready to handle the postoperative issues that happen after transsphenoidal surgery. The second factor that influences surgical outcomes is tumor location, and I will show you some slides to illustrate that in a minute. The third factor is how severe the biochemical imprint of acromegaly is. The higher the growth hormone level, the least likely that the whole tumor will be successfully removed. And finally, when a patient goes for any type of surgery, the associated diseases should be in as good control as possible. So for example, if there is an issue with heart failure or untreated sleep apnea that could pose a problem for intubation, extubation, these patients need to be seen by their physicians, heart-lung specialist, definitely endocrinologist, and the better the diabetes control before any surgery, the better the outcome of that surgery. Here are some pictures to illustrate that some tumors can be completely resected. On the left-hand side, the arrow points to a low-density lesion right here, which is very small. It's called a microadenoma, is far away from the optic nerve and is not invasive. And this tumor, which was diagnosed early, has an excellent chance of total tumor resection. Now on the right you see a larger tumor. However, this also seems to be contained, seems to be just in the space of the pituitary gland and non-invasive. So it may have a good chance to be completely resected as well. Unlike here. As you see here, this is like an eccentric donut, and the black circle here is the patient's left carotid artery. This is the artery that supplies blood to the brain. No neurosurgeon, no matter how good, can get to this part that is lateral to the carotid artery without a significant risk of causing a stroke. So the surgery here will be debulking, so incomplete tumor resection, all this part here. So about 80, if not 90% of the tumor can be still removed, while a residual will remain postoperatively. So that's how important is the MRI and the discussion that the patient should have, the honest discussion that they should have with their doctors before proceeding to surgery with regards to what will surgery mean in my case. What do I expect from surgery? The benefits of surgery are that one can see an immediate improvement of most manifestations of acromegaly. As we were saying, the joint pain is the least likely to go away completely, but otherwise things like sweating and headaches will improve quite quickly. Surgery is the only therapy that gives the acromegaly patient a chance for durable remission, which we tend to call cure, but actually I don't like this term too much, because even if a patient goes into remission, which means that the tumor is gone and the levels look normal at 3 months postoperatively, even in that situation, the disease unfortunately can come back. That's called recurrence, and it's rare, less than 12% patients of acromegaly, but we should never forget about that, and we should continue to monitor the patient. So again, a benefit is the chance of durable remission in those patients with non-invasive tumors which only cause a mild to moderate elevation of the growth hormone. Another benefit of surgery is the fact that the tumor specimen goes to the pathologist, who can provide a lot of information to us, and we can use that information in when we choose the type of medical treatment we will give to the patient. And finally, tumor debulking increases the success of postoperative medical treatment. So even in this situation, when the patient will still have a tumor, but smaller, on the MRI at 3 months postoperatively, and will still have some growth hormone elevation, it is likely that we'll need a smaller dose of medication that will control its disease, and smaller dose sometimes translates into less side effects. How about the risks for surgery? So bleeding, infection, spinal fluid leak can occur. These are fortunately rare, especially in expert hands. New pituitary hormone deficiencies can occur. If you go back to that initial slide with so many hormones, 8 hormones that we know of made by this gland, the master gland of the body, sometimes if the tumor is large, despite the surgeon's best efforts to separate the tumor from the normal gland, there are deficiencies. And in these patients, they need to take either hydrocortisone, which replaces cortisol secretion, or levothyroxine, which replaces thyroid hormones, or gonadal steroids, testosterone in men, estrogen in women. Sometimes there is excess thirst and urination. We call that diabetes insipidus. That can also be treated with pills called DDAVP or desmopressin or spray. Now, fortunately, new permanent pituitary hormone deficiencies are rare in the hands of expert neurosurgeons, maybe something like 10 or 15%, and maybe one hormone could go down, not necessarily all. But transient changes in hormones are actually quite prevalent, and that's why, again, you need a center where they've seen these changes before and they can help patients timely. So let's do a case study. A 45-year-old man with acromegaly underwent surgery. He now feels better, but hormone levels are still significantly elevated at 3 months post-operatively. That's when the new baseline is established. At 3 months, the patient must have that visit with the endocrinologist, hopefully on the same day. The endocrinologist and neurosurgeon can both meet the same day with the patient and discuss what the labs are and what the MRI looks like. So at 3 months, this patient is being told that the levels are still, unfortunately, elevated, improved but elevated, and the MRI shows a sizable tumor residual in the cavernous sinus. So that's that part, the lateral part close to the carotid, where the carotid artery is. So another surgery is really not recommended. So next, this is where we start talking about medical treatment for acromegaly. This patient is certainly a candidate for medical treatment or acromegaly. He has a large tumor, and this is why it would be useful to use classes of medication that act on the pituitary tumor in itself. There are 2 classes that are available to us, somatostatin receptor ligands. There are 3 of them approved for treatment of acromegaly by the FDA, and dopamine agonists approved for a different indication for prolactin-secreting tumors, which also have been used for quite a while in treatment of acromegaly. So we have 2 classes of medicine that act on the tumor. That's probably what would be the case in terms of treating. That's probably what's going to be needed in this patient. We're not going to talk right now in this patient about the growth hormone receptor antagonist. That's another class of medicine. But as you can see, it acts on the growth hormone receptor. So it induces a normalization of IGF-1 levels, but it doesn't do anything to the tumor. So in the case before, a patient with a sizable tumor and high levels of IGF-1, what we need to give this patient is a somatostatin analog. There are 3 medications available, octreotide, lanreotide, and pasireotide. The first 2 are depicted in red, have been around for a long time, and they act on several somatostatin receptors, and as you can see, there are 5 of them, but the main effect is on somatostatin receptor 2, which is fortunately a receptor that is present on most pituitary tumors that secrete growth hormone. The new medication called pasireotide, which was approved by the FDA sometimes late 2012, acts mostly on somatostatin receptor 5. So it has a better effect on this subtype receptor, so it's an advantage for the patients who have a different receptor proportion on their tumor. And this is where research has to bring more details in and personalize these treatments. Like when you have the tumor specimen and you know more about it, then you can choose a little bit better. So let's look at these medicine. The first 2 apply to the same medicine called octreotide. You can give subcutaneously every 6 to 8 hours. This is a short-acting version. But most patients then transition to a more convenient once-a-month octreotide LAR preparation, which is injected by a nurse in the muscle. It's injected usually every 4 weeks, and we have several doses available. We change the dose depending on how the patient feels, how they tolerate it, and the IGF-1 and growth hormone levels. The second medication, lanreotide depot, is administered deep subcutaneously. The interval can be larger than 4 weeks. It just depends how much the patient needs. And there are 3 possible doses that one could inject. And the new medicine called pasireotide depot, also intramuscular as octreotide LAR, also every 4 weeks, and there are also 3 possible doses. How to choose, right? Personalized treatment, how to choose between what is available to us. Well, we know from many studies done over the years in this medicine that have been available for a while, octreotide and lanreotide are very similar. They tend to decrease the growth hormone and IGF-1 in the same way, and I hope this graph shows you how they almost overlap. And they also tend to shrink the tumors. Now keep in mind, it's not an effect of normalization of levels in most patients. Normal levels are only achieved in 20 to 40%, but most patients fortunately experience a significant improvement of their levels, which leads to better clinical situation. They feel better, and also many patients exhibit tumor shrinkage. The differences between these 2 medicines that have been around, have been in our pharmacies for a long time. The differences are really the formulation. The lanreotide depot, due to its nanotube formulation, comes in a syringe that is already pre-filled, does not require reconstitution. And the injection, the needle is shorter but thicker, so it's a deep subcutaneous injection, versus the octreotide LAR that requires reconstitution by a nurse, and then the injection is intramuscular. The other aspect of this difference in formulation has to do with the prolonged. So with lanreotide depot, we can extend the interval of administration up to 8 weeks sometimes, because it tends to be an effect that is more lasting. The new medicine, because it's not even 4 years old since it's been approved, pasireotide, has been shown in a head-to-head study, direct comparison with octreotide, to be more efficient at reducing IGF-1 levels, also called somatomedin C. So it's more powerful, sounds like. In terms of tumor shrinkage, the effect was similar, and I think these graphs illustrate it. How about the side effects? Somatostatin analogs have a set of side effects that is more like a class side effect, and there is one single aspect that we know of at this point that differentiates the new versus the old somatostatin analogs. Diarrhea, abdominal pain, and nausea tends to occur with the first injection, and it can last few hours or it can last few days, and usually it gets better with repeated injections. If the dose is increased, then the side effects can come back, but again, just for 1 or 2 injections, usually then they get better. Cholelithiasis or gallstones can occur. There's the sludge, the slowing of the gallbladder, so one has to be careful. Nasopharyngitis has been reported, pain and nodules at the injection site. So all these so far are common to all somatostatin analogs. And the physicians will also monitor things like the rhythm on an EKG or the thyroid function tests, other things that can happen with these medications. Glucose problems, however, are quite rare with the old somatostatin analogs, octreotide and lanreotide, but they are quite frequent with pasireotide. And that's what this graph shows. It shows how the mean hemoglobin A1C, shown in the darker line, is significantly elevated with pasireotide LAR versus octreotide LAR. So about 7 out of 10 patients treated with pasireotide LAR will have some glucose elevation. It doesn't have to be necessarily in the range of diabetes, but it may go up from baseline. So that's something that differentiates pasireotide from octreotide and lanreotide, and that's something that one has to keep in mind, because the glucose goes up quickly, a week or so afterwards, and the patient and the physician need to communicate about that. Let's move to case study number 2. A 35-year-old woman with acromegaly underwent surgery. She feels better, but hormone levels are still slightly elevated at 3 months postoperatively. MRI shows a small tumor residual, and the patient would like to have another child soon. What to do next? Well, this is the time to talk about dopamine agonists, because they've been studied in women with prolactinomas, which is a different type of pituitary tumor, for a long time, and they are safe to use for these women at least up until the time when they conceive. And then when pregnancy is confirmed, the medicine is usually stopped. There are 2 types of dopamine agonist available, bromocriptine and cabergoline. Bromocriptine is not effective in acromegaly. Cabergoline used alone is effective in less than 30% of patients. But if it's added to somatostatin analogs, then it's effective in 50% of patients. The doses of cabergoline required for control of acromegaly are higher than those used in patients with prolactinomas. This is used outside the FDA specific scope, so such discussion has to happen between the patient and the physician to make sure that the patient is comfortable with that. And predictors of success, just like in our case, a slight elevation of IGF-1 levels, usually no more than 1.5 times limit, would give this patient a higher chance to respond to cabergoline, which is a tablet, than someone who has a more significant elevation. Another predictor of success is prior radiation, but obviously we're not going to give radiation to someone who doesn't have a large tumor and wishes to get pregnant soon. This is one of the studies that showed how effective cabergoline with a somatostatin analog, this was either lanreotide or octreotide. If you look at this dotted line, this is where you would like to see everybody. Yeah, this is where the IGF-1 level started in the squares, the dark squares, and then look how many of them, about half of them, got to levels that are below dotted line. If they started with high numbers, they almost never got to the dotted line. But if the levels were only slightly elevated, greater than 1.5 or less above normal limit, then you see quite a few patients who are responding. Case study number 3. A 45-year-old man with acromegaly underwent surgery and treatment with maximal dose octreotide LAR. Feels better, but hormone levels are still elevated. The MRI shows a small tumor residual. What to do next? So this would be the case to add a growth hormone receptor antagonist. There is only one that has been approved by the FDA and available prescribed, called pegvisomant. Because it acts on the growth hormone receptor and not on the tumor, we do not need to monitor growth hormone levels, just monitor IGF-1. It is very effective. If I was to choose a medicine that is the most effective in normalizing levels, this is pegvisomant. It normalizes IGF-1 in most patients after dose titration. Higher doses are needed for those with higher levels. It is a daily subcutaneous injection, and it may cause abnormal liver tests. The patient and the physician must agree on a schedule of testing the liver test that initially is on the monthly basis and none less frequently. And of course, injection site reactions can occur. This is the study that included a lot of patients, close to 300. As you can see, more than 60% of patients normalized their IGF-1 levels at 5 years. And this is the dose that they've used. The maximal dose is 40 milligrams daily. So in other studies where the dose was titrated to 40 milligrams, this number of responsive patients with normal IGF-1 goes as high as 90%. On the other side, pegvisomant does not shrink the pituitary tumor. It does not act on the tumor, so we shouldn't ask for this to happen. Some patients experience tumor growth, especially if the somatostatin analogs were taken away and replaced with pegvisomant. So that's why in the case study that I just gave you, I would keep the somatostatin analog if it did something, if it shrunk the tumor or improved the levels, and then I would add pegvisomant. I would use a combination treatment and try to target both the tumor and the growth hormone receptor to get to normal levels, but to continue to control the tumor growth. It is important to repeat the MRI 6 months after starting pegvisomant and then on an annual basis if the patient doesn't have headaches or new headaches or vision changes. And finally, case study number 4. This is a 45-year-old man with acromegaly who underwent surgery and combination treatment with lanreotide depot and pegvisomant, both used at maximal doses. Feels better, but growth hormone levels are significantly elevated, and MRI tumor shows a tumor residual. So that is a case of severe acromegaly that has been resistant to both surgical and medical treatment. What to do next? This is where radiation comes in. Radiation for acromegaly takes time to work. In fact, with any pituitary tumor, it takes time to work. These are benign tumors. And here's what I would like you to see. So the mean follow-up is for a few years. Maybe, somewhere between 4 and 6 years, the most for all these studies. And the remission means normal IGF-1 and growth hormone levels is on this column. So I would like you to see that the longer the patient is followed, the higher the rate of remission, but also the higher the rate of pituitary hormone deficiencies, because sometimes it's just difficult to target just a tumor without affecting the normal gland surrounding it. So a patient who undergoes radiation for acromegaly must remain in control, in endocrinological control every year at least, or sooner if they have symptoms. Their cortisol, their thyroid, and so forth should be monitored, because radiation have these side effects that can occur later on, either at the 10 or 15-year mark. So adverse effects of radiation, low pituitary function. Also, if a too high dose of radiation is administered too close to the optic nerve, then vision loss can occur. This is rare because radiation oncologists know how to use a single fraction, which can be gamma knife or linear accelerator or proton beam, or they can use fractionated radiotherapy that is usually done over the course of 5 years. So, because if the optic nerve is close to the tumor, the radiation should be done in a fractionated fashion. Rarely we see cases of second tumor formation. They can occur many years afterwards, and the jury is still out with regards to cerebrovascular events and neurocognitive dysfunction in patients undergoing radiation. Radiation techniques have improved over the years, and it takes a long time to see the full effect of radiation. So these are really research cohort studies that have to be ongoing for decades in order to answer these questions. These are the recent guidelines in patients with acromegaly, and as you can see, surgery is the first line for most patients. In some patients who are poor surgical candidates, medications can be considered. before surgery, but generally everybody gets surgery first, and if there is disease, acromegaly, high numbers, or incomplete surgery, then medications can be used. And I hope that with this talk that I just gave, now you understand a little bit better how the physicians think when they give patients somatostatin receptor ligands, octreotide, lanreotide, or pasireotide, dopamine agonist, cabergoline for mild disease, or pegvisomant, which is very efficient but doesn't act on the tumor. They are both listed here because we have to personalize the treatment for each patient one by one. Here is what the radiation is if the medicine were intolerable or were not tolerated well or were ineffective. So the choice of medical treatment in acromegaly, first generation somatostatin receptor ligands, octreotide, lanreotide, normalize IFGF1 in up to 50% patient and may decrease tumor size. Second generation pasireotide may be more effective but associates hypoglycemia 70% of cases. Dopamine agonist cabergoline, not bromocriptine, can be tried in patients with mild biochemical acromegaly. Pegvisomant, the growth hormone receptor blocker, normalizes IGF-1 in most patients, but further tumor growth may occur. And further research is needed to identify predictors of response in order to achieve as early as possible the control with treatment that is good for that patient, individualized. Instead of conclusions, I would like to say acromegaly patients benefit from early diagnosis, a multimodality, multidisciplinary approach. The team must include an excellent neurosurgeon, an experienced endocrinologist, potentially a radiation oncologist. The neurosurgeons often work with ENT surgeons, neuroradiologists, neuro-ophthalmologists, a team that can look at the whole patient. And the patients need to have lifelong follow-up. And this was it, and I am ready to take any questions.
That was excellent. Thank you. I do have a couple of questions. If a patient has had to take hydrocortisone, levothyroxine hormones, and DDAVP since original surgery 15 years ago, can a new surgery to remove regrown tumor correct any of these, or will medication be necessary for rest of life?
Excellent question. I would like to say that 15 years later, it is very unlikely to undo the deficiencies that occur as a result of first surgery. Most deficiencies that occur as a result of the tumor growth or surgery in itself, we can work to see if these deficiencies go away in the first 3 to 6 months after surgery. So that's when the endocrinologist is trying to figure out whether that hydrocortisone or levothyroxine are still needed by doing blood work in a certain fashion in relation with how the medicine is taken. 15 years later, I would think that it is unlikely to turn the course back to where it was to normalcy. But definitely another evaluation would not harm anybody, so the evaluation could be done, but a new surgery is unlikely to achieve such an ambitious goal.
Okay, thank you. That actually, I think, answers the next question too, about cases where hormone deficiencies reverse after recovery. So I guess 3 to 6 months is kind of the telltale time when that would occur.
Yes, and it depends how long the deficiency was there. So the way I tell my patients is I look at this as an elastic that is being stretched. You stretch the elastic for a little bit, it will come back to its original shape and size. You stretch and stretch and stretch, that will no longer happen, and the fibers are going to start to break, right? So if this is a large tumor that was there for a long time, it's caused these deficiencies, the chance for those deficiencies to go away as a result of surgery are small. But it still has to be reevaluated. I would say in general, about 50% of patients experience some improvement. But again, between improvement and normalization of the function, it's a difference.
Great, that makes sense. Thank you. I am a male 60 years old patient who had surgery, medication, and radiation 7 years ago. I had to stop the testosterone medicine as it rocketed my PSA levels. Is there a tolerable limit for increased PSA level?
Hmm. That is a question for the urologist because PSA says only part of the story. This is about the prostate, right? So PSA is a blood work that is done in men, and this is done in conjunction with a digital rectal exam, which pretty much evaluates the size of the prostate gland, whether there are nodules and so forth. So testosterone is the fuel for prostate in healthy men and in men who underwent surgery for their pituitary glands and then require testosterone replacement. Patients are going to feel better because they take the testosterone, but their prostate might not feel the same. The prostate might become larger, which is called hyperplasia, or BPH, benign prostate hyperplasia, or there could be nodules there, and some of them can be cancerous, that can grow faster as a result of the testosterone replacement, whether it's injection or gel or so forth. So PSA is one way of looking at the prostate situation. There are other ways, and urologists should be involved in these cases. They can do the digital exam, they can do ultrasound, they can do other tests, and it is the urologist who should say whether testosterone is safe or not. There are some cases when the prostate is removed and then the testosterone is then administered again. So there are several ways to go about it, but I think this is more a urological problem at this point.
Okay, thank you. With high IGF-1 levels, what is the best medicine, in your opinion, to try to conceive on?
Yes, so I've touched a little bit on cabergoline because with mild acromegaly, which means mild IGF-1 levels, cabergoline may work. You've seen the graph there in about 50% of the patients. Patients with acromegaly have trouble getting pregnant. And if you normalize your IGF-1 levels, that the chances to become pregnant go up. So I would start with trying cabergoline, and it will take a few months because nothing happens right away. And if that is not working, then lanreotide subcutaneously is considered the safest way to go. There is not enough data out there to say whether long-acting somatostatin analogs like lanreotide, pasireotide, or even octreotide long-acting are safe, and also non-sufficient data for pegvisomant. Definitely, I wouldn't do radiation. If the patient didn't yet have surgery, that's something to definitely consider. So for a woman who wishes to become pregnant and has acromegaly, surgery, subcutaneous octreotide, and cabergoline could all be considered. You know how they say the details are everything, right? Like how high are those numbers? What does the MRI look like, and so forth, because we tend to follow very closely women with growth hormone secreting tumors during pregnancy as well.
Okay, thank you. I have no signs of residual tumor yet. Had to start lanreotide due to IGF-1 levels continuing to go back up. How can one tell if a second tumor is somewhere else?
So it's very rare that acromegaly resides anywhere else but the pituitary gland. Those cases are extraordinarily rare, they are not a case of growth hormone secretion per se. It's a hormone called GHRH that can be made by some other neuroendocrine tumors that can hide in the lungs or in the pancreas. But if our listener had surgery, and surgery demonstrated a growth hormone secreting tumor. The pathology report stated that there was a growth hormone secreting tumor that was found, then that's where the acromegaly is coming from. So the fact that we're not seeing the residual just has to do with how small the residual is and where it is located. MRI is great to visualize pituitary tumors. However, its detection limit is about 3 millimeters. So there could always be a very tiny residual tumor that is yet too small to be seen. But I think the question the patient has can be answered if the pathology clearly indicated that was a growth hormone secreting adenoma.
Okay. I seem to have symptoms that return about 3 weeks after a shot and have to wait another week before the next one. Do you have any advice on how to control or minimize these breakthrough symptoms?
Yeah, excellent question. So first, I would like to see if the symptoms are truly due to the medication effect going away. So the medication is weaning off and then the symptoms come back. The way to demonstrate that is with blood work, just to see what the IGF-1 level is right before the injection, maybe the morning of the injection, but before it, and then maybe a week or two before, just to kind of establish and demonstrate that this is indeed happening. And if this indeed is happening, this is a dilemma because these medicines are not supposed to be administered more frequently than every 4 weeks. Either the patient can go on combination treatment if the levels are higher than normal, or can go back to subcutaneous octreotide, because if you take the same thing 3 times a day subcutaneously, each day should be the same as next one. It's not like the level is higher right after the injection and then much lower 28 days later. And I know that there are clinical trials as well with oral octreotide, which involves taking twice a day pills for acromegaly, which also should answer this issue of the breakthrough symptoms. It's really, the solution seems to be in taking something every day rather than allowing an injection to keep the symptoms in control for 28 days. The oral octreotide, I didn't put it on the slides because it hasn't yet been approved by FDA. The research is ongoing, so that is a research topic, but the patients can go to clinicaltrials.gov, which is a United States central research registry, and they could read about the research opportunities available there. But yeah, that would be my my advice, to try octreotide subcutaneously 3 times a day to see if anything changes, but first get the levels that prove that there is some slight lack of control towards the end of the interval.
Excellent, thank you. That concludes, it looks like, the questions. I think we've answered all of them. If anybody has any, get them in there quick. Looks like we are good and kept it into our hour. I think we'll end here. This has been excellent information. We really appreciate your time and all the valuable information. This concludes today's webinar presentation. We appreciate you taking the time to join us. If you missed any part of this webinar, or if you would like to share it with friends or family members, we will have it available on our website after it's edited. The P&A wishes to thank you for participating in our webinar. There'll be a brief survey after the webinar. Please fill it out to help us provide you with the information that you need. Thank you for joining us, and enjoy the rest of your day. And thank you, Dr. Ioachimescu, for this great information.
Thank you for having me. It's been a pleasure.
Have a great day. Bye.